these neurological disorders, we know that they can arise in either the central or the peripheral divisions of the nervous system. Typically, your more serious are going to be acute problems that are going to happen in your central nervous system or CNS, but your peripheral nervous disorders can be very painful or debilitating as well. You can have altered mental status, behavioral changes, neurological deficits. Those are some of the more common manifestations of your nervous system disorders, but they have other causes as well. So with this, it's really important that you understand the patho behind these disease processes so you know what actions you need to do or the importance of your actions to try to improve or maximize the potential for recovery, mostly by preventing your secondary brain injuries, recognition, things like that. All right, so just a quick little review here. We know that the nervous system is divided into the central nervous system, which is the brain and spinal cord, and the peripheral, which is all of the neural tissue outside of the brain and the spinal cord. And then functionally, the nervous system is further divided into the somatic or voluntary and the autonomic or involuntary divisions. The autonomic division is further divided into parasympathetic and sympathetic, and this is what is responsible for our homeostasis. The parasympathetic is responsible for your vegetative functions and reproduction, while the sympathetic is responsible for the stress response. All right, and they work together to meet the demands of the bodies to overall functioning. So overall, our nervous system is monitoring input from the internal and external environments, and it's going to integrate this sensory input from the environment and coordinate your responses to that input. We get input from the external environment, from the somatic sensory receptors, and that's going to be like your vision, your hearing, touch, things like that. And we get them from the internal environment from our visceral receptors, such as the baroreceptors that are measuring your blood pressure, and chemoreceptors that are measuring your carbon dioxide and oxygen levels in your blood and stuff. And this input's going to travel through your afferent nerve fibers to your CNS. When we are assessing these neurological complaints, we have to work from that patient's presentation, their complaint, and their history to see if this problem is due to a neurological cause or if there's something else going on. They may present with your altered mental status, they may present with your behavioral changes, both good and bad. They may present with your sensory impairments, headaches, weakness, paralysis. There's a long laundry list of things that they may present with. So you've got to know, have a good understanding of the nervous system, but also the various causes of these different presenting signs and symptoms so that you can decide on your field impression. You've got to have that knowledge there to develop and test your hypothesis and your clinical reasoning. All right, so number one, first thing, of course, scene safety, right? Ensure your safety and the patients and your partners before beginning care. Now, this may be super easy. They may be at a residence somewhere and they're just passed out on the couch. Or it could be a little more complicated. If you've got multiple patients with altered mental status showing some similar signs and symptoms, you want to think about a toxin. And the problem with that is, whatever affected them could also affect you. So we don't want that. I don't know about y'all, but I want to go home at the end of my day. I want to go back and see my family. All right, so if that does occur, don't go in. Get to a safe place. Notify dispatch of possible hazardous material, hazmat situation. Let them know ASAP as soon as you suspect it. Be suspicious. It'll help keep you alive. All right, we're going to look for any indications that the problem may be neurologic. Let's say they're altered mental status. And let's say it's because they overdosed. Well, an indication there might be they've still got a needle hanging out of their arm. Well, clue, number one, but also safety problem, right? Because there's a needle in their arm. And when you move them, that needle could fall out and poke you, and we don't want that. I don't think you want that. Most people don't. So, you got to look and see overall what is the cause of this, what could potentially going on, or potentially be going on. So once we assessed our scene size up, we're going to look at our primary assessment. So of course, unresponsive, you check their cardiac pulse, and if they don't have a pulse, you start CPR. All right, so assuming they have a pulse, we're going to determine their level of responsiveness using that AVPU. Right, and that's that alert, verbal, responsive pain, or unresponsive. Now, it's very important to note, the patient may be awake, but they probably are going to need a more in-depth mental assessment or mental status assessment in the secondary assessment. And here we're looking for confusion, difficulty in thinking, impaired memory. Kind of like lights are on, but is anybody home, You could have the lights on in a house, but that doesn't necessarily mean there's somebody in there, right? Somebody can be alert, but not be cognitively there as well. So it's real important to look at that cognitive function as well. Now we're going to determine the adequacy of their airway, breathing, and circulation. With our neurological problems, we know we have neurological control of the gag reflex, of swallowing, and in the airway. It's really important because if they have a diminished neurological function, their airway is in jeopardy and they could aspirate. All right, excuse me. They could lose control over the tongue, which could flop back and block the airway. So a couple of different things that can happen there when they lose some of that airway control there. All right, we need to intervene to establish and protect that airway in whatever need, however is appropriate for that particular patient. We need to make sure that patient's adequately ventilated and oxygenated. Any patient who has ultramental status or whose airway, breathing, or circulation is compromised is a critical patient and a high priority for transport. We absolutely must detect and correct hypoxia, because impaired oxygenation of that brain tissue is going to worsen the outcome. It can cause or be the cause of a secondary brain injury. All right. Poor perfusion, hypoxia, hypoglycemia all lead to poor outcomes for neurological patients. We don't want that. Now, once we've moved on, we've got our ABCs handled. We're going to look at our secondary. This is where we're really going to fine-tune it and figure out most likely, hopefully, what the cause is. So once we've done this, we've done any initial interventions. All right, we're going to get more information about their medical history. If they're awake and can tell us, tailor your questions to the complaint. Use your sample, your OPQRST, to get your complete and relevant history. If they're not able to offer a chief complaint or provide a history, get information from family, bystanders, friends, whoever may be able to give you any kind of information there about what's going on, both history and current. Medications can also provide a vital clue to some underlying problems, and we'll look at some of those in just a moment. We want to get vital signs. We want to get pulse oximetry. We want to get any patient, every single patient with altered mental status or a history of diabetes needs a blood glucose. Period. Done. All right, get a blood glucose. If they're critically ill, consider using capnography. Okay, and if it's in your protocols, consider cardiac monitoring. For our critical patients, we're going to perform a rapid physical exam, and for our non-critical patients, we're going to perform a focused physical exam. Now, we also want to consider the possibility of some increased intracranial pressure. Okay, keep in mind that we must have adequate mean arterial pressure, or MAP, to overcome the resistance of that ICP, or increased intracranial pressure. If that intracranial pressure rises from cerebral edema or bleeding, something like that, that MAP also must rise to maintain cerebral perfusion. All right. When you have this increased blood pressure, especially in your systolic blood pressure, it's often accompanied by a reflex bradycardia, and we will actually see that as a Cushing's reflex. Okay, that ICP that we associate there. Now, you also are going to want to look for some specific signs in your secondary assessment. We're not just shooting some buckshot at it and hoping something sticks. We're looking for some specific things here. We want to look at mental status. We want to look at neurologic exams. Okay, these are very important if you suspect a patient suffering from a neurological problem. So a neuro exam is going to include assessing the pupils, looking at response and size. We're going to assess the motor and sensory function of all four extremities. We're going to use a stroke screening tool if we suspect it's a potential stroke. We're going to get a GCS if we have not done so already. And in some areas, you may even see a mini mental exam being beneficial. And this is where you're looking at stuff like their affect, how they're presenting themselves. Do they seem unusually anxious, worked up, angry, sad, depressed? Looking at their speaking. Are they talking like Eeyore and they're so sad? Or are they talking like this, like they just did a whole line of coke and there are a little mosquito flying around, da, 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 you know? Look at their speech patterns and their word choices, and do they seem to be in touch with reality? That kind of stuff is included in the mini mental exam. So some of our stroke scales here, we've got the Cincinnati pre-hospital stroke scale and the Los Angeles pre-hospital stroke scale. You can see the different things that are involved in them. And the Cincinnati actually has some parts of the FAST as well, the FAST scale. So you're looking at facial droop, arm drift, abnormal speech, and you don't necessarily have to have them say that sentence, but you want to tell them a sentence and have them repeat it back to you. And we're checking to make sure that they remember the words, but also that there's no slurring speech or anything, like no aphasia or anything like that going on. With your pre-hospital strokes, kind of like a little chart, you would kind of check yes, unknown, no, and then it goes through some of your more common potential patients who may be more prone, say, to a stroke, and then goes through a little an exam as well. And of course, you've got your GCS, which your first section, the eye opening, is just an AVPU scale. All right, then verbal response, oriented and converses is 5, disoriented and converses is 4, inappropriate words, which would be the wrong words, 3, incomprehensible, if they're making noises like that, that's a 2. All right, and if there's no response at all, they're a 1. The computer you are listening to this on, or the tablet, or whatever you're listening to this on, is a 3. There will never be less than a 3. All right, and then of course motor response, obeys verbal, localizes pain, withdraws from pain, flexes in response to pain, extends in response to pain, and then no response at all. Once again, is a 1. Some of those medications that could indicate your neurological disorders or issues here: amitriptyline, Tegretol, Thorazine, Aricept, Neurontin, Haldol, Levodopa. There's a whole list here, and there are more than this, but these are some of the more common ones that you may be able to see. Now, keep in mind that just because somebody takes this medicine doesn't always mean they've got a problem. I have heard of people taking Neurontin for who have like severe back pain. I have heard of people taking, Dilantin, also for mood disorders. Propranolol is a beta blocker, so, there are other things. Depakote also sometimes is used as mood stabilizer, so there are other things as well, but if you see these just kind of trigger a history of neurological issues or problems there. So things we want to make sure that we are looking at and thinking about. All right, these problems, altered mental status, behavioral emergencies, headaches, slurred speech, things like that, they all could indicate a neurological emergency, but they also could have other underlying causes. So you've got to understand the basic function of the nervous system and how it works so that you can create this list, differential of what's going on, and then just systematically work through it and see what could be causing this. So a mnemonic to help you remember this is AEIOU tips. And I always feel like I kind of stutter, like I feel like I'm falling down the stairs when I try to talk say that. But AEIOU tips is a mnemonic. And so what it is, A is going to be alcohol or anoxia. E is going to be an epilepsy or environment. I is insulin, all right, or other endocrine disorders. O is going to be overdose. U is going to be uremia or other, renal failure. T is going to be trauma. I is going to be infection. P is going to be psychosis or poisoning. And S is going to be stroke or shock. So now obviously this is not an all-inclusive list, but this is just a quick mnemonic. We love our mnemonics in EMS to help you remember some of the more common or more likely possible causes of altered mental status in a patient. Okay, now we're going to break these down into extracranial and intracranial. Extracranial means the problem is outside of the brain itself. So this would be your infections, your metabolic problems, your acidosis, your alkalosis, your hypoxia, hypoperfusion or shock, environmental, toxins, things like that. Okay? And then intracranial would be like the TBI, traumatic brain injury, your stroke, your seizures, epilepsy, things of that nature. It's important to differentiate here because some of these extracranial problems we can do something about, okay? If that problem is hypoperfusion, could we fix it? Maybe. If it's hypoxia, can we fix that? Good chance. If it's hypoglycemic, can we fix it? You better. Overdoses, ditto. So there's a lot of different causes here that we need to be able to identify pretty quickly and then hopefully correct this problem. And most of them are going to fall in line with correcting an A, B, or C, an airway ventilation or oxygenation and circulation problem. Okay? Other causes like your intracranial, we can't fix that. We can't address the underlying problem. We can't do anything there, but we can try to improve the outcome. So we're still going to manage our ABCs, our airway, ventilation, oxygenation, circulation. We're going to control any bleeding. We're going to help maintain adequate blood pressure in a trauma patient with a brain injury. We're going to try to prevent these secondary injuries. Okay? If we suspect a stroke, or if there's a trauma or traumatic brain injury or something, we're going to transport them to the right facility so they can get to definitive care quicker, which can make a huge difference in their overall outcome. As far as reassessment, they can deteriorate very, very, very rapidly. So, of course, your standard critical every 5, non-critical every 15, but keep assessing them as you go. Keep an eye on them, keep reassessing, and if you do a good, thorough assessment, about the time you're wrapping up one full reassessment, it's about time to start the next one. Right? We're going to be performing our primary assessment again. We're going to measure our vital signs. We're going to recheck any relevant aspects of that secondary. We're going to ask about any changes. We're going to look at their mental status, their pupillary response, any other pertinent neurological exams, and we're going to look at any interventions that we may have performed. Also important to note here, if you have a significant change in presentation, i.e. your patient was responsive and now they're unresponsive, we're going to immediately stop wherever we are in the reassessment, and we're going to go back to the ABCs. We're going to go back to that primary and start like it's a new patient because they've had a substantial change. If they were unresponsive and now they are responsive, ditto.